You are listening to In the Thick of It, a podcast from the HCM Society, where we interview experts in the hypertrophic cardiomyopathy field to broaden the awareness of new HCM studies and advancements.
Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
What are left ventricular apical aneurysms, and why do they pose such a high risk in hypertrophic cardiomyopathy patients? In this episode, Dr. Ethan Rowin and Dr. Jeffrey Geske delve into this rare but critical HCM phenotype. Listen in to learn how to accurately define and detect apical aneurysms, the importance of advanced imaging techniques like contrast echocardiography and cardiac MRI, and the elevated risks of sudden cardiac death and stroke these patients face. They also discuss evolving guidelines for ICD patients and the nuanced role of aneurysm size and risk stratification. Let's get in the thick of it. Here's Dr. Jeffrey Geske and Dr. Ethan Rowin.
Ethan, you kind of have the seminal paper, I feel like, that showed how important these are in patients with HCM. Maybe let's just start by how you defined apical aneurysm in that key paper, and then we can kind of launch into, I guess, various different aspects of care of patients who have apical aneurysm. So tell us, how do you define an apical aneurysm in someone with hypertrophic cardiomyopathy?
So it's typically seen in patients who have either mid-cavity hypertrophy or apical hypertrophy, and they have discrete thin-walled aneurysms, meaning akinetic, dyskinetic segments at the true apex. Typically, these patients have transmural scarring. Then I think it's also important to differentiate that this is not patients who have obstructive coronary disease that causes an MI leading to an aneurysm formation. This is part of the hypertrophic cardiomyopathy phenotype.
Yeah. And when you're thinking about this, is it something that you find is separate from apical hypertrophic cardiomyopathy? Do you see it in non-apical hypertrophs?
Yeah, so great point. I think so. A really important principle here is we're not talking about patients who have apical hypertrophy, right, thickening at the apex. This is a distinct phenotype where there is actually thinning at the apex, so a true aneurysm formation. And important to realize it's also a pretty uncommon subgroup of patients with HCM, depending upon the paper, although have less than 5% of all HCM patients who have this unique disease feature.
And it's something that can develop over time. If you're following someone who has some predilection to this, whether they have an apical phenotype or whether they have, profound midventricular hypertrophy or severe midventricular obstruction, this is something that over time, as you're following patients, can develop. It's not that if you have reached adulthood or something that you won't get an aneurysm. Tell me your thoughts, Ethan, about apical pouches, because it seems like sometimes we can get a change in the LV cavity at the apex that maybe doesn't meet all of the criterion that you just described for the definition. Maybe they don't have transmural scar or necessarily akinesis or dyskinesis, but they do have a change in the shape from that ace of spades to now having a little cavity out at the apex of an apical pouch. What do you think of that scenario?
So, first, their HCM patients have an extraordinarily heterogeneity in their distribution of hypertrophy. So these hearts look weird in general. And in some patients, you can have these abrupt transitions from hypertrophy to wall thinning, which we all know at the apex, the wall is typically thin. And so sometimes you can see what you and others have described as a pouch, which is where the apex is thin and there's this abrupt transition, but is not aneurysmal, meaning there's still contraction at the apex. And so that is not, again, what we're talking about here in terms of an aneurysm.
Yeah, and I kind of wonder if there's not some natural history effect there, that patients who have begun to develop that abnormal LV cavity at the apex don't maybe even have increased risk of progressing to that thinned, scarred, aneurysmal phenotype. And we're kind of looking into that a bit, but I do think it's key, especially as we talk about kind of clinical impact and treatment decision making, to recognize that it's not necessarily having a little bit of an extra cavity there at the apex. It's more so about making sure that it truly is an apical aneurysm, which maybe brings us into another topic of how do we actually image these and figure out that difference. I'll put you on the spot, Ethan. What's your take? Do all patients with apical HCM need a cardiac MRI, or is echo sufficient for some? Or give me your approach.
So first, I think when you just look at a routine echo, not done necessarily at Mayo or other experienced HCM centers, the aneurysm not infrequently is missed. In our cohort, which was now going back many years, almost 50% of patients with apical aneurysms did not have it seen by non-contrast echo. And so when you see apical hypertrophy or midventricular hypertrophy, you really have to look for the aneurysms. I think that's important point one, which is often really need off-axis imaging to really look at the apex and make sure that there's no aneurysm there. Two, and you're much more of an echo expert than I am, so maybe you want to talk a little bit about contrast with echo and who you give it to, and then maybe I can come back and talk a little bit more about CMR here.
Yeah, I think I would reiterate what you said: off-axis imaging, and having a mindset to prove as you're imaging whether there is or is not an aneurysm. It's not something that always shows up on standard views. If you simply take a 4-chamber, a long axis, and a 2-chamber apical view, you could very easily miss an aneurysm. And then as you're thinking about this, you're coming with a new patient that you're evaluating with apical HCM. You're taking a patient that has significant midventricular hypertrophy. I think then contrast really increases our ability to find these. So it increases the sensitivity of echo for detection of apical aneurysms. And my gut approach when I'm seeing a new patient with apical HCM is to strongly consider a first study to include contrast, just because I really want to prove that that is or is not present. And then if I'm seeing that patient in return, whether to do contrast on subsequent evaluations, I think does depend on image quality and the thoroughness of off-axis imaging. But I will say, with some frequency, I still advocate for serial studies that include echo contrast, because it really does improve our sensitivity at finding those aneurysms. And those patients may not be headed to serial MRIs at that same frequency. I would maybe transition back to you with the leading thought that while I've just advocated for high quality echo and off-axis imaging and contrast echo, that I absolutely value and see the synergy of CMR imaging. And would you say the same? Do you use them in concert?
Yeah, completely. Our protocol is routine, echo imaging for these patients, in terms of serial follow-up for HCM, and then routine use of contrast as well as part of our protocol. In contrast, in my opinion, every patient who has HCM who doesn't already have an ICD should have a cardiac MRI when you're, during their initial HCM evaluation. And then part of that is, looking for aneurysm and scar. And that shouldn't just be, a run-of-the-mill MRI. Our protocol is also a stack of images throughout the left ventricle so that you can see in long axis, make sure that there is no aneurysm. But then, we're repeating MRIs every 3 to 5 years, depending upon the patient profile. And so, in between that, looking for aneurysms, really the workhorse is echo and echo with contrast. And then obviously if there's a question but not a definitive aneurysm by echo or vice versa, that's the role of multimodality imaging to help resolve.
And although it's not a part of our initial order set or kind of routine evaluation of new patients, many times patients with HCM have had this meandering road to diagnosis, and they may have been through emergency departments or other care facilities where they've had CT of the chest. And I think that sometimes going back with this lens of HCM in mind and looking at the apex in someone who's had a triple rule out scan and an ED, sure, they don't have a PE, but maybe they didn't notice that they have an aneurysm present. And so I do think that although not a protocol part of evaluation, CT is certainly something that can be helpful in recognizing presence of an aneurysm.
Yeah, completely agree. And then also obviously gives you the added benefit of, you definitely want to exclude coronary disease in these patients as a mechanism for their aneurysm formation. So you obviously get that information with the cardiac CT as well.
And I do think that one particular additive feature of CMR that you've highlighted is that we can see late gadolinium enhancement. We can look for that transmural delayed enhancement, which is a part of kind of the definition that's been used in your seminal paper and in many others, and helps us figure out, is this truly aneurysm or is this some pouch or other kind of cavity change that doesn't fit our criterion for aneurysm. Let's say you find it. What does it matter, right? So, I mean, first off, you said it's not super common. Why go through the extra work of off-axis imaging and echo contrast that might not have been given for other reason, and synergistic CMR? Why do you care, Ethan?
Yeah. Our group and others have really described this as a particularly high-risk phenotype. And that most importantly, I think, relates to sudden death risk, which appears substantially increased in these patients. In our cohort of patients, sudden death events, which includes sudden death, but also out-of-hospital cardiac arrests or appropriate ICD shocks for VTVF, was almost 5% per year. So really high even for HCM, and higher than other major risk markers. The Toronto group separately have also reported this substantially high risk, and nearly 20% of the NYU group also with apical aneurysms had sudden death events. So clearly a high risk phenotype for ventricular tachyarrhythmias. And for this reason, the 2020 and then the 2024 AHA-ACC guidelines consider apical aneurysm as a major risk marker, and presence just of the apical aneurysm deserves consideration for primary prevention ICD.
I think there's been a lot of shift just in how we think about sudden death risk stratification. And you see some of the maybe older markers that some might be familiar with, non-sustained ventricular tachycardia or treadmill-associated hypotension. These sort of things that used to have, I think, more weight have really been moved down. And now both LV systolic dysfunction, EF less than 50, and presence of an apical aneurysm have become class 2A indicators to pursue ICD implantation. It's exciting to see our understanding of sudden death evolve and change. And I think that of those class 2A indications, true apical aneurysm is one that is a more villainous component. It's something that certainly you don't want to miss as you're thinking about sudden death risk stratification. So why isn't it in the ESC calculator then? Like, what's going on with that? I mean, do you think it should be?
Oh, well, my biased opinion, yeah, absolutely. The Europeans have published that it's not part of their guidelines. And the reason for that is because there is a high overlap with aneurysms and other high-risk features, but the most common of that is non-sustained ventricular tachycardia. That's really, to me, more of a chicken or an egg type question, right? You're saying that you're not considering aneurysm as a risk marker because there's a high proportion of these patients who have NSVT, but we know that NSVT in these patients occurs right above the aneurysm in a transition zone of scarring. So it's saying you're not considering an aneurysm as a risk marker, only NSVT. And to me, that's kind of really missing the mark of what's the driver for sudden death risk.
And as we get more and more ambulatory monitoring, whether it's loop recorders or wrist-worn devices or cardiomobile, whatever those are, I think we're seeing that the signal of non-sustained VT is present in a lot of patients with hypertrophic cardiomyopathy, whereas the risk marker of an apical aneurysm is, I think, a much more discrete and smaller identified group. So I'm with you. To me, I think it's actually a strength of the ACC algorithm and something that when I'm looking at both approaches, which I certainly use while counseling patients, I think it's actually one of those things that makes me really value the 2020 and the 2024 ACC AHA algorithm.
What are your thoughts about size in aneurysms? Do you think all aneurysms represent increased risk, or do you think that size matters here?
Well, okay. Here, we were joking that we may have some differences. I'm curious to see because I think it's fair to say this is an area of controversy. Okay, and currently the ACC guidelines it's for irrespective of size, and I think that your seminal paper actually also was independent of size. But please correct me if I'm not remembering that correctly.
That is correct.
With both of those things said and out in the open, I think it probably does matter. And so you're nodding. Okay, so we're not going to get in a fist fight
No,
here.
there's no
This is
we're on the same page here.
okay. So I think that presence of an aneurysm is a villainous marker, and I think that that identification of that at present is enough to serve as a 2A indicator. I think a really big aneurysm probably has a multitude of bad things that go along with it. In addition to elevating sudden cardiac death risk, I think that a large stagnant pocket of blood predisposes to thrombus formation, which may have embolic risk. And I think it also predisposes to heart failure. And so we kind of get this multi-pronged negative effect, whether it extending beyond sudden cardiac death risk stratification. What's your hot take?
Yeah, I agree, and let's just keep for a second on sudden death risk, and then we need to talk about stroke risk. I think there's more data emerging that size can matter, and specifically, particularly small aneurysms are probably do not represent the same amount of increased risk for sudden death. That being said, I think as of today, we don't have the clear cut point in terms of what size represents enough of a risk to consider primary prevention ICD. So I think as of today, the takeaway should be, consider ICD implant independent of size. But I think there's going to be a lot of emerging data going forward that size plays a role. And I wouldn't be surprised that in an update of the guidelines in a few years, if we see that change in terms of having a more of a size definition related to sudden death risk.
And do you think that it's related to scar burden? Do you think that it's the amount of LGE associated with larger size aneurysm? Or do you think that there is some hemodynamic mechanics properties that when you get a large aneurysm and you have this large transition zone from hypertrophied heart to dyskinetic apex, that this serves as a nidus for ventricular arrhythmias, or both? Or what do you think is the critical difference between a small and a large aneurysm for arrhythmia risk?
Yeah, So I think obviously all hypothetical, but I agree with your second theory a little bit more, that there's more of this transition zone. So in the patients who have recurrent monomorphic VT or VT storm, this is a subgroup of patients where VT ablation actually has a pretty reasonable success rate. And the mapping in those patients is that the VT origin seems to be, as you mentioned, the transition zone between the transmural scar and then the mid-wall scar just above it. And so I think it's probably that you have a larger burden, with larger aneurysm, larger burden of this mid-wall scar that's the nidus for ventricular arrhythmias.
Yeah, I think that makes sense. And it will be interesting to see as we learn more and more about LGE quantification, if including aneurysm scar should be a part of that, if it's a separate thing. It is a really great time to be in HCM care because of our evolution of understanding of the disease.
Great. So you mentioned this, and I agree. I think next point we should definitely cover is stroke risk. Should we be considering anticoagulation based on the aneurysm? Does that depend on size? What's your practice? So there's data that suggests that presence of an apical aneurysm is associated with increased risk for thromboembolic events because there's stagnant blood flow in the aneurysm, which can lead to clot formation. So do you use prophylactic anticoagulation for all aneurysm patients?
So I will say I think my practice varies, and I polled our HCM group about this, okay, because I just wanted to see, and I think that there is some differences and subtle changes in how people approach this. I will say, as an offset with a more definitive answer, that I would not empirically anticoagulate a pouch. Because that does not provide the same nidus for thrombus formation that an akinetic or dyskinetic thin wall does. And so I think even if you're on that side of anticoagulating all aneurysms, I would be careful not to extend that into anticoagulating pouches.
Completely agree, and that important principle for sure.
I think next, if someone has been identified either on contrast echo or on CMR as having thrombus associated with their aneurysm, then that's also very easy. That seems like we should anticoagulate those individuals because this is a source for cardioembolic stroke. Now, when you whittle it down more and you say, hey, we got a very small aneurysm, should we anticoagulate everyone with that feature? I do think that there's some shared decision making that goes on there in my practice, recognizing that there's a signal for increased stroke risk. I have not taken to anticoagulating every single one of those patients. Ethan, do you anticoagulate them all? Am I making it too complicated?
No, first, I agree. I think this is, again, another area where more data is needed. And then, again, this is an area where the AHA-ACC guidelines do not recommend universal anticoagulation just based on presence of aneurysm. There's, again, emerging data that smaller aneurysms do not appear to be associated with the same risk of thromboembolic events. So my clinical practice is when the aneurysm transverse dimension is over 2 centimeters, I push a little bit to anticoagulate in that as part of that shared decision-making conversation. But when it's smaller than that, I still talk about a risk, but I'm not pushing as much because I think the data is much weaker, and I explain that to the patients as part of that conversation.
What about spontaneous echo contrast? Where there's smoke, is there fire? Would you say does it influence your decision making or not? You say you have someone there, they measure 1.9. I'm that mean. 1.9, but then they've got a smoky apex with spontaneous echo contrast. Does that stagnation of flow, does it play any influence on you or not so much?
I'd remeasure it and make it 2-1.
That's when it's time for multimodality imaging, so that we get some. Yeah,
No, I'm joking. It's always there's always, as you know, a little bit of clinical gestalt with everything. And so if you're seeing a lot of stagnant flow, again, that might be a reason to to discuss with the patient a little bit more about anticoagulation in terms of risk. So all those things go into the thought process, but typically you see, to me, and interested in what you guys are seeing as well, I see much more stagnant flow in the medium to larger size aneurysms than you do typically with the smaller aneurysm.
Yeah, I agree. And now let's say someone's got an aneurysm and you've done appropriate risk stratification and you've made your shared decision making about therapeutic anticoagulation without use of blanket anticoagulation. What in your practice makes you want to go to surgery, to aneurysmectomy? When does it get to the point where you'd say, is that driven by arrhythmia? Is it driven by stroke risk? Is it driven by heart failure? Is it all of those possibly? When do you think about, let's go chop off the aneurysm?
So first, I think you downplay, which I know you're doing intentionally, downplay the magnitude of the surgery for this. And I'm very interested in hearing your thoughts and your experience because Mayo has world-renowned surgical team that really matured the technique for apical myectomy and aneurysm repair in these patients. So my understanding of this in terms of the surgery and approach really comes from data from you and your team completely. That being said, to me, it's really driven more by heart failure symptoms in terms of an apical myectomy and aneurysm repair, as opposed to seeing a clot, which most of the time when you anticoagulate will resolve. And then VTVF, if they're asymptomatic, then I think that's the role for catheter ablation in my practice. So it's really driven by advanced heart failure symptoms. But the key there is, again, this to me is not just a typical myectomy, and even more than the traditional myectomy where it should be reserved for a high volume center. Not just because you're a high volume myectomy surgeon doesn't mean that you're a good apical myectomy surgeon. And really, there are very, very few centers in the U.S. Where that is the case. But yours is the premier center for apical myectomy. So definitely interested in hearing your thoughts there, Jeff.
I agree with everything you've said, Ethan. The primary driver for consideration for apical aneurysmectomy, I think, is going to be heart failure. I will share that we've had a few cases of refractory VT where for various reasons we thought that that aneurysmectomy was actually the treatment of choice. I agree, catheter ablation should be explored and looked into, but there have been a few times where arrhythmia has been the prompt for this. I think that even at very high volume centers who are very experienced, that the morbidity mortality associated with apical myectomy and with apical aneurysmectomy, which are not necessarily the same thing, and we'll just make sure we clarify that, is higher than that of transaortic myectomy. And to me, that makes sense. You're making a left ventriculotomy, and you're debulking this complex tip of the heart. We know that entering the LV apex in many studies is not associated with great things at times, right? If you even just hearkening back to the TAVR data. And so you really want to make sure that you understand what the apical anatomy is. So in advance of proceeding to aneurysmectomy or apical myectomy, making sure that we've defined the anatomy there really well is important. Understanding what the stroke volume is, understanding what the LV cavity volume is, looking at cardiac MRI, cardiac CT is sometimes we use that to help understand that anatomy as well. I think that's very important. Now, apical myectomy can be used for treatment of deeper obstruction, say obstruction that maybe you can't get to from a transaortic septomectomy, like midventricular obstruction. It can be used in non-obstructive patients to perform cavity enlargement, essentially to improve LV stroke volume and improve filling pressures. Or it can be coupled for aneurysm removal. And I think there again, we get to the fact that this is not contributing to contractile function. It's akinetic or dyskinetic. And so you get this pooling of blood in the apex that can lead to someone having LV contractile performance issues. Along those lines, Ethan, I think you've hit the nail on the head with the fact that you really want a surgeon who's comfortable with approaching this. And if it's someone who might be a great transaortic septomyectomy person, may still not be the right person to do transapical myectomy.
I completely agree, and I think the number of patients in the United States, in my opinion, who need aneurysm resection with an apical myectomy is low, and these operations really should be pooled to very specific centers in the U.S., which obviously includes Mayo Clinic for that operation for sure.
But what about a myosin inhibitor? What do you think? I mean, would you give a myosin inhibitor to a patient with apical aneurysm?
Yeah. So first, because there's some confusion out there, I think it's prudent to really highlight that when you're talking about myosin inhibitors, the FDA approval and the patients it should be used in is patients with left ventricular outflow tract obstruction from systolic anterior motion of the mitral valve with septal contact, resulting in high LV systolic pressures. We are not talking about midventricular obstruction. Myosin inhibitors are not approved for that use. There is no data to support efficacy, but more importantly, safety in those patients. They were not part of the published clinical trials. So they, in 2024, in my opinion, should not definitively be used for this subset of patients.
I remember when we were recruiting for Valor, I had a patient with severe dynamic mid-ventricular obstruction. And I was thinking, maybe this is someone, that we were thinking about actually surgical management of this, yet they were excluded from the trial. So it's not that there's a low number, but this was actually not studied in those trials. And it is being studied now in some ongoing trials. They're actually mixed in with non-obstructive patients. The trials that are looking at mavacamten and aficamten in non-obstructive cohorts have a subset that are mid-ventricular obstruction. It will be interesting to see that data, but I would not generally favor using this in those scenarios outside of a trial because it's not been studied. That's off-label. That's not the right thing to do.
Off-label in a restricted access drug, again, equals no, just to be clear. But obviously, as you mentioned, 2 ongoing clinical trials in 2026 or 27, if we're invited back to give another podcast, that might change. But in 2024, absolutely not.
I've seen it actually done. Not by me. I will just be very clear, not by me. But I've cared for a patient that was referred to me for some questions, and they were using it, and I said I'm not comfortable with that because that's not what this should be for. But okay, let's say you have a patient and they have dynamic outflow tract obstruction from SAM. They're symptomatic from their outflow tract obstruction, but by the way, they also have an apical aneurysm. Does it give you pause?
Yeah, it does give me a little bit of pause. Obviously, that's a different scenario. That is where outflow obstruction is where myosin inhibitors have been studied. But it gives me a little bit of pause, right? Because it is a strong, they're very strong negative inotropes. They can lead to systolic dysfunction. and here you have an akinetic area in the apex, and now you're adding this really potent drug on top of that. So that certainly gives me pause. I probably would, all things equal, favor septal reduction therapy for that patient. What are your thoughts there?
Yeah, I think it gives me pause in the same way as if I saw a patient who has an EF of 60 and a ton of scar, right? We're talking, a huge amount of late gadolinium enhancement. I think I would say I'm a little bit more hesitant to give someone a potent negative inotrope in that substrate. But we're getting into the area where it sure would be nice to have more data, but I'm on the same page as you that would make me pump the brakes.
Jeff, so this has been great conversation. Maybe now is a great time, I think, for some kind of key take-home points and to wrap up.
Yeah, I think, let's see, my key take-home points. I'll do 3 and then see if you've got anything else. I think identifying apical aneurysms is important, and ensuring that we're actually looking at an apical aneurysm and not an apical pouch. I think 2, that multimodality imaging is really a highlight of how we study and understand apical aneurysms. And I think 3, that when we're caring for patients with hypertrophic cardiomyopathy, especially when there's complex questions like this, we just did like an off-the-cuff podcast about this, and we still got into the weeds, and it's wonderful. I think I would have a low threshold to involve high volume centers of excellence, because there's so much changing in the landscape of HCM, and getting the best care for those patients may involve calling a friend. Ethan, what did I miss? We got to say something in the highlights about sudden death risk, right?
Yeah. So I completely agree with every one of your points. You're now talking about a rare subset and relatively uncommon disease, and so referral to people who are really experienced taking care of these patients is key. That being said, I think when you see an aneurysm, in addition, really start thinking about that as a major risk marker and consideration for primary prevention ICD as well.
And you published the seminal paper. I show it to patients. Man, it's congratulations again on that. I know it's years old, but man, what a huge contribution.
Appreciate that. Thank you. And as I said, the work that your group has done in terms of expanding our treatment, or expanding our treatment for these patients as well, in terms of apical aneurysm resection and apical myectomy in these patients is outstanding. So,
well, great joining you today. Thanks for joining us on this podcast.
That was Dr. Jeffrey Geske and Dr. Ethan Rowin. To learn more about the HCM Society, please visit hcmsociety.org. This episode was edited and produced by Earfluence. Thanks for listening, and we'll talk to you soon on In the Thick of It.